Hi, my name is Dr. Robert Kaufman, and we're about to go beyond Terminus. Today's topic is emergency treatment, part 3, the acute apical abscess, or what's known as the AAA. This is the third of the 3-part series on how to manage patients with endodontic emergencies. If you haven't, go back to the other 2, and you'll see how we handle things like reversible and irreversible pulpitis. Today, we're going to discuss acute apical abscess. The AAE glossary defines the acute apical abscess in this way: an inflammatory reaction to pulpal infection and necrosis characterized by rapid onset, spontaneous pain, extreme tenderness to tooth pressure, pus formation, and swelling of associated tissues. There may be no radiographic signs of periapical destruction, and the patient often experiences malaise, fever, and lymphadenopathy. These patients arrive in your office and they are acutely ill. Because the diagnosis is fairly obvious, management of these patients rather than the diagnosis becomes the main priority. The primary considerations for getting the patient comfortable are, number 1, adequate anesthesia, and number 2, obtaining drainage of the abscess. In the case of the acute apical abscess, although the clinical manifestations of the disease are periapical, the source still remains the necrotic pulp inside the tooth. It's important to differentiate between a localized acute apical abscess and cellulitis. Both are managed differently. I always prefer to attempt to access the tooth first and get canal patency when possible. This has 2 purposes. First of all, it removes the necrotic pulp as a source of any future periapical irritation. And secondly, by obtaining sufficient drainage through the tooth, we will frequently prevent the need for incision and drainage. It's sometimes necessary to have the patient sit in the chair for quite a while as we watch the sequence of the drainage that follows the classic purulent, pus, then sanguinous, bloody, and then serous, clear tissue fluid sequence of drainage. Serous drainage in larger lesions can be quite prolonged. Microsuction of the canal assists with evacuation. When a localized fluctuant swelling is present and the swelling is pointed, it's generally very easy to provide minimal anesthesia to the soft tissues, sufficient to allow for a small incision and drainage procedure. Massage and manipulation of the soft tissues around the incision to encourage drainage can often provide sufficient emergency relief on its own. Once the acute symptoms have subsided, the patient is scheduled for proper endo treatment. In the case of cellulitis, the abscess has not localized sufficiently. Swelling is often firm and more diffuse. The abscess has not pointed yet, and attempting to do an incision and drainage is generally not only ineffective, but extremely uncomfortable for the patient. The pH of the tissues is influenced by the cellulitis, and adequate anesthesia for soft tissue drainage is sometimes harder to achieve. It's frequently a better idea to try to open the tooth first, obtain any drainage through the canal, and then place the patient on an antibiotic that assists with pointing of the abscess to allow for eventual incision and drainage in a day or 2. It's always preferable to close a tooth rather than leave it open to the oral environment and further contamination or trapped food. If this is not possible, every attempt should be made to see the patient as soon as possible to complete the clean and shape calcium hydroxide medication of the canals. The only times in which systemic antibiotics are indicated are when, number 1, the patient has compromised general medical status, such as if they're immune suppressed. Secondly, if the extraoral to facial cellulitis is associated with fever or malaise, or you suspect systemic involvement. Or 3, when the swelling can potentially compromise the airway. These are extremely rare situations nowadays in most modern societies. Managing patients with the acute apical abscess in your office can be some of the most rewarding and effective ways to manage the reputation of your clinic. There is nothing better for your practice than a patient who tells others how skillfully you managed their situation and provided them with profound relief. They're your best ambassadors. If you're comfortable managing such acute care situations on your own, your endodontist will be glad to assist you with management of the patient. Resist the urge to write a prescription in the hope that the antibiotic will deal with your acutely involved patient. These patients deserve immediate, skillful clinical management that provides them with relief from their symptoms. I hope that these short presentations will help you manage your symptomatic patients more efficiently. Thanks for watching. Please join me again on our next trip when we go beyond the Terminus.